So welcome to this college webinar on failure. My name is Karis Grimes. I'm a Consultant General and Colorectal Surgeon specialising in inflammatory bowel disease at the Medway. I'm also recently appointed as the Associate Medical Director for Patient Safety and Quality, and I sit on the governing body of Surrey Heartlands CCG as an external person onto that CCG, but I also have sight of some of the Surrey Hospital serious incident reports. So what we're going to talk about this evening is really about failure and mistakes and how we manage them, how we learn from them, and how we challenge some of the cultures within our departments and our trusts that stop us learning and stop us really being honest about the things that we probably need to in order to be able to learn, both as individuals and departments and as trusts. So the way we're going to do this evening is I'm joined by three fantastic colleagues here, Ginny, Peter and Greta. I'm really grateful to them for joining me on this really difficult topic and something that we all feel very acutely, particularly as surgeons, because I think surgeons can be particularly affected by things that go wrong. So what we're going to do is we're making an assumption that most of you, or hopefully all of you, will have listened to the two podcasts that Ginny and I have done on failure, and we therefore want to allow a lot of time for questions and discussion from everybody who is listening in. So what we're going to do is we're each going to introduce ourselves. And then I think we've got one slide each, which from our sort of perspectives, from our different perspectives on failure and mistakes and learning. And then we're going to open it up to your questions. And I'm sure that there'll be an awful lot of discussion. There's so much we could talk about around these topics. So thank you. Can I ask my colleague, maybe Ginny first, to introduce herself?
So I'm a consultant vascular surgeon at Medway Maritime Hospital with Karis. I'm also head of School of Surgery for Kent, Surrey and Sussex and the vice chair of the Vascular SAC.
Thanks, Ginny. Peter?
No, please, not Greta next, please.
Okay, Greta.
Oh, bless you. Such a gentleman, Peter. Thank you so much.
You've made an error, Karis, already, you see, look.
Well, we can't have a webinar on failure and everything go well, but yes, Greta, yes.
So I'm a higher surgical trainee, surgical reg in Kent, Surrey and Sussex. So Ginny is now my head of school. Hi, Ginny. I'm also a leadership fellow at Cleveland Clinic, London, and co-founder of Women Speakers in Healthcare. Peter.
Brilliant.
Yeah, thank you very much, and it's an absolute honour to do this evening with three lovely ladies, and you know, so I'd always put you first, and actually Greta coming before me does a great thing of lowering hierarchy, which is a lot of things we talk about as well. So, you know, there shouldn't be a hierarchy or steep gradient anyway between consultant and trainee. We should be on a level playing field. Anyway, my name is Peter Brennan. I'm a maxillofacial head and neck surgeon based on the South Coast in Portsmouth. I'm an elected RCS council member as well. Done a lot of work on human factors and error, and had a lot of errors and failure myself as well. So speak from experience on that, both clinically and with exams and all sorts of things. Thank you.
Thank you. So next slide, please. So one of the things I'm really interested in, and the reason this webinar is called Failing Intelligently, is as I say to my trainees when they say, look, Miss Grimes, I think I've really screwed up here. So don't worry, I have written the book. And I've written quite a personal perspective, but called Failing Intelligently. And it's really to try and encourage people to talk about failure. That was the main purpose for the book. I want people to feel free to be able to talk about the things that go wrong. And the reason sort of sometimes we learn or we don't learn, or our organisations learn or don't learn, are multifactorial. But we know that there are individual factors such as the mindset of the person. And there's been a lot of work in education, and any of you with kids may have heard of this term growth mindset, and the sort of converse, which is fixed mindset. And fixed mindset people are people who are identified by their successes or their failures. Now, if your identity is in your success or your failure, then it will be really hard to admit to doing anything wrong, because it's such a personal identity issue for you. And therefore, people with fixed mindset, they don't seek feedback, they're very reluctant to admit to mistakes, they try and blame everybody else. Whereas growth mindset people see their failures as separate from themselves and as tools to learn from, and that's what we want. We want colleagues and people who are willing to learn from their mistakes and aren't going to be too scared to admit to them, and not feel that they're so defined by what happens that they're not able to be honest about stuff. But there's also organisational factors. So you can be the most growth mindset person in the world, but if you're in an organisation where you will get blamed and you will be gossiped about and your reputation will be ruined, then there is absolutely no way you will ever admit to doing anything wrong, because we don't want our reputations ruined. So, but the problem is that if we don't look at these mistakes as ways of and look for the learning in them, then we as individuals can't learn and improve, and the organisations and departments that we work in can't learn and improve either. So that's basically what this slide sums up. Next slide, please. Oh, yes, there's some additional there.
I think this is my slide. I mean, from the perspective of how I started discussing this with Caris was because in Caris's role in governance, she reviewed all the SIs, and I was involved in an SI on an elective patient. And I went through all the emotions and Caris and I started discussing it, which was how the podcast came about. So what's my perspective? Well, it's my perspective is I have failed as a surgeon, and I failed badly at that time. And Caris helped me to fail well. Within all of this, we have to remember that the patient comes first, the patient and their family are our first thought within everything that happens when we have an adverse event. And, we can quote percentages to patients of failures. And, when we've been on the receiving end as a patient ourselves, you assume that those failures aren't going to happen. You aren't going to have the 1% risk of something happening, but it's a disaster when it does happen. And it's very hard as a surgeon then to actually acknowledge that you've got emotions about it, because you feel guilty, because the patient should come first, the patient and their family, and therefore for you to say that you're impacted by it is very hard. But it's important that you acknowledge that you are impacted by that adverse event. And it doesn't matter whether you're a trainee or whether you're a consultant or a non-training grade. It will undoubtedly affect your confidence, and you'll feel guilty. You'll go and kick the door or cry or however you cope with your coping mechanism is. So I would suggest within this that we need to put the patient and the family first and what they're going through. We need to be open and honest in what has happened, and we need to learn from what has happened. But within that, we need to consider our own well-being. PHP, or Practitioners Health Programme, is a service, an NHS-funded service set up for doctors with mental health problems. And only 4.3% of their patients are surgeons. Now, either we're incredibly resilient and have no mental health problems, which I suspect is not the case, or we're just very reluctant to go and seek help, because that is a sign of failure. And as surgeons, we're not used to failing, we're used to being successful. We need to know where we can go and get advice. And we need to admit that we need that support. And the reason that I put the article, the supporting surgeons after adverse events here, was because this was published last year and has the concept of creating first responders, which is something I'm very interested in creating for my trainees in CareSess, so that if they're involved in an adverse event, they'll have someone to go and seek help from within the deanery. The quote from René Lariche shows that this isn't a new problem, this isn't a new issue that we're dealing with. This is from the 19th and 20th century. It's been around for a long time. But it's time as surgeons that we admit that it's a problem and seek the help that we need. Thank you. Next slide, please.
Oh, it looks like it is me next. So, I think you touch on some fantastic subjects straight away. So, looking at the organisation, looking at that just culture, and it's so much easier to blame someone else rather than being inclusive. And so, when I when I have a failure or we have an issue or complication as part of the team, and it might be a trainee, for example, that's doing an operation and puts a hole in the jugular vein or whatever it is. Now that trainee knows that they've actually done that mistake, but I'm not going to blame them. I'm going to say we as a team. So we've had this problem today. How are we going to deal with this? And so dealing with that acutely, that's the first thing. And then obviously at the debrief, then we can talk through and how do you think this happened and things. So I'm not actually blaming, and I think that goes a long way for for speaking up for culture and things. I mean, I've had huge numbers of failures, and in fact, I failed the old FRCS as it was in the late 90s at the Royal College of Surgeons of England, and many of you probably won't remember, but the chap used to walk down the stairs, and I think there were 3 people that passed on that day, and my number was 116 or whatever it was, and so he went 109 and then 120, and it's like, hang on, you've missed me out. And so I understood why. I went and sat the exam again, and I failed the exam for the second time. And I then thought, that's it. I'm gonna leave. I'm gonna do aviation medicine, or I'm gonna do something else. And then after a lot of thought, and of course there was no support really. It was just, you failed the exam, get on and do it again. And then I sat it again. And was lucky enough to pass, and subsequently became chair of the Court of Examiners and then the lead for the whole MRCS in the UK and Ireland. But the point is that failure gives you empathy, gives you an understanding of what it feels like to fail a postgraduate exam. So you have empathy with the candidates, and failure is normal. You have to understand that we all have failure. Error is normal. I put that in inverted commas. So we're not designed as humans to multitask. We're not designed to do all this complex things really. We've evolved very rapidly. If you think about it, over the last 100, 200 years, we've evolved at such a rate, and the more complex stuff we do, the more likely we are to fail. And I've had some pretty serious surgical complications as part of a team. One catastrophic complication about 9 or 10 years ago, and I walked out of that theatre, and in fact, Karis, it's exactly what you said. It's an organisational type thing, and it was just a number of factors lining up, to be honest, that caused that. And I thought, I'm never going to operate again because I internalised it. I blamed myself. I took the load. I went to the family and admitted that the complication, and we were crying with the family. Emotion is really important. To empathise, and I was really upset. Anyway, patient eventually made a satisfactory recovery, and you move on from the experience. But just learning from failure. So I think Cicero. You talked about your thing, Jenny, from the 1700s. Well, Cicero was a Roman poet in the 1st century BC. And he said, if you don't learn from failure, that's the mistake. So, so many failures along the way, and the more failures you have, the more success you have. So yeah, thank you very much.
Thanks, Peter. Next slide, please.
Lovely. Thank you very much. As you can see, I've chosen a slide that says experience is simply the name we give our mistakes, from Oscar Wilde, which is maybe perhaps slightly tongue-in-cheek from Oscar Wilde, but I think is also very, very pertinent and something that we're all obviously talking about. I think I come at this from a obviously slightly more junior, maybe less experienced is perhaps the word, but let me tell you, I have had my fair share of failures up till this point anyway. When I was younger, I was and what I would now class as an elite swimmer. I didn't quite go international, but that's because I was coming to medical school and had to make that tough choice, but I was competing at a national level. And something that I think competitive sports teaches us that is very similar to surgery is actually sometimes you can be at your fittest, swim a PB or run a PB, perform the best operation that you think you ever have, and still something goes wrong. In my case, you know, you would still lose. You still wouldn't win the gold blooming medal, even though you'd given it your absolute all. You'd done a perfect technique. There was just somebody that day that was better than you. And that was something that I learned fairly early on in my life career, really, is that sometimes you can give it your absolute all and you still just don't get it for whatever reason. Can be quite a bitter pill to swallow. But I think it taught me quite a lot of resilience, and also taught me that you've got to learn from your mistakes. I remember sitting down and looking through videos of my swimming races, trying to work out why they beat me. Was their technique better? Had I messed up the turn? Was my start slightly off? And I think that's something that is starting to become normal, particularly with our sort of learning from excellence, but also in discussions in M&M meetings about where things went wrong. Well, how can we mitigate that? And like Karis was saying, that individual and organisational, it's not always your fault. There is other extenuating circumstances sometimes. But I think also having that humility of being able to say, actually, you know, I did get this wrong. A quick, brief career summary of my other failures as well. I failed some exams at the first year of university, and that was absolutely devastating. Spent my summer resetting. Then in my second year of uni, basically failed every single exam that you could possibly fail. I was quite ill during that year. Again, extenuating circumstances. I had mumps, then got post-viral syndrome, and then got gastroenteritis, managed to lose 1.5 stone, and I was sort of only 9 stone at the time anyway. So it was pretty catastrophic, but resat the year. But I think for most of my university career, I had this big sort of weight around my neck that I was a failure. It's taken me quite a long time to look back and go, actually, there were quite a lot of extenuating circumstances going on there, and sort of have allowed myself to take that break and say, actually, I'm not a failure. It was just a really crap year in your life. And to sort of find peace with that. I have also failed the MRCS a couple of times, but passed the Part B by 1 point. So I'm pretty sure that means I did the perfect amount of revision. Thank you very much. Needed to do just what I needed to do. But I say this to the SHOs that I try and mentor and say, actually, you know, if you do fail it, kind of so what? You know, it's an exam, it's rubbish, you will learn from it. You can bet your bottom dollar you will probably try that a little bit harder next time you do it. So I hope that's reassured some people in the audience as well, that they are not alone in having made mistakes and failed exams. We're all in it together. And Karis, I very much liked your get to the back of the line. Was it you or Ginny in the podcast where your boss came in and said, get to the back of the line, we've all made these mistakes. So I think that's definitely a summation that we're coming to on this talk so far. Next slide.
Can I just come back to Greta just for a second, because we've actually published with Olympic rowers and just about performance. So we did a fairly large study several years ago, actually, to be honest, and looking at performance of rowers compared to surgeons. That's available. And when you go to the Leander Club at Henley, there's only names of the gold medalists, and they're in gold. All the other rowers, even though they might have come second or third or whatever at the championships, they're in black, and that's really kind of humbling. That, you know, there's only one winner, and that's to win the gold medal, even though these people are right at the top of their game. So you know, everything else is a failure if you don't get the gold medal. It's just unbelievable.
But I think in sports as well, it's almost that killer instinct of, you know, like you say, you know, if you're in the Wimbledon final, you want to beat and destroy that other person to be the winner. And I definitely think that competitive edge has sort of carried me through in surgery. And I know that surgeons are definitely competitive, but I think you also have to have a softness to it as well. I don't think that sort of killer instinct runs through very well in surgery. And I think it's something that in this world of collaboration can sometimes be a disadvantage. You know, we're all talking about collaborative working now and sort of teamwork. Throughout most of our careers, we're taught to be the best, and we're taught to you know, your deciles at uni will help you factor get into your jobs and national selections. So it's an interesting one.
Brilliant, thank you. So I think that's the end of our slides. So we're opening up now to discussion for questions from anybody. I don't know, have we got any questions yet? Because if not, we can generate lots of discussion between us.
We have got a couple coming through. The first couple are on a sort of similar theme about sort of your personal sort of experiences and strategies. So our first question focuses on trainees, and the participant comments that trainees are not often taught about how to deal with complications or failures. It's not part of any sort of curriculum per se. And they are asking what sort of strategies that you as a panel have to help cope or deal with failures, complications, setbacks in a clinical setting and a personal setting.
Fantastic question. Greta, do you want to start with that one?
Yeah, I think it is. I mean, it is taught, but it's part of the hidden curriculum, isn't it? Which is just a whole other discussion in itself from a medical education point of view. I think it's a really tricky thing, and I think it very much depends on who your boss is, where you're working, and what the mistake is. I remember my first year as an F1, I forgot to book an ITU bed for a patient, and when I remembered it, when they were halfway through the big esophagostrectomy, and they were halfway through the operation, we sort of realised this, and your stomach just sinks. I was like, oh no, I'm going to get shouted at. Oh, it wasn't even that I'm going to get shouted at. It was just that I've messed up and I've just, it hasn't gone right. Long story short, managed to get them an ITU bed. I think somebody had sort of picked up on it, but it wasn't there. Went in and actually went into theatre and sort of grovelling, was like, very sorry, Mr. Surgeon, I forgot to book the bed. And actually they were fine. And I think we're a bit taken back by the fact that I'd actually gone in and apologised and had said, okay, well, you know, we all make mistakes, don't worry about it. Thank you for sorting it out. And that's something that stuck with me. I think it would be wonderful to have some sort of organised teaching on how failure should be dealt with, or what counters as failures, because the ones that we experience as trainees are, I think, have much less of an impact to us because we move on so quickly. I think they actually, it's yourselves as the consultants who sort of mop up the mess, unless it's something like a serious incident or it goes to the coroners. I think the smaller complications, which almost like doing the appendices, which teach you how to do the bigger right hemis, which teach you how to do the anteriors, we don't have that feedback of, well, what was a small complication that happened? How do you deal with that? And like Peter said, the emotional side of it, how do we emotionally process this, accept that we may have done harm to somebody through no fault of our own, just because that's the business that we're in. Ginny, you're my head of school. What do you think?
Well, nicely passed. Well, you're also talking about when you failed exams, and actually, I mean, for me, primary FRCS was my nemesis. And although this isn't a competition, I actually failed it 13 times. And when I passed it, I know even the course of the examiners came up to me and congratulated me because he said he'd failed me 3 times himself at the Sherry. But what actually happened, what changed for me was the psychological side, that I was going to stop taking it, and I was supported to go and do a course. And I looked at everyone else around me and could see they were all expecting to pass and were fresh and enthusiastic, and I was just trolling along for another failure. So in that was a change of mindset for me to want to pass that exam. And in actual fact, once I passed that exam, I straight next sitting got my FRCS and was a registrar SPR within a year. So it took me a year from passing primary to becoming a registrar, and it was simply that changing of mindset. So I think if you're talking about failure in exams, I think it is definitely, that's down to mindset, and positivity has so much to play in that, apart from, of course, doing the work and learning it. from the perspective of patients and failures, no, we're not really taught how to cope with that. And a lot of it comes, I think, for trainees from their consultants as role models. And we can't underestimate how important our responses with patients, with families, with duty of candour is as a role model to our trainees. But then I started this by saying that I failed badly with a case because I'm only a human being, and I found it particularly difficult when that happened. You know, how do we learn to do that? And I mean, I'm working on something with the Royal College at the moment, the professional passport, and Peter and Greta are both involved with that. And one of the parts of that is developing a section on failing and failing intelligently. So we do hope the college will be hoping to, within this programme, help to train and teach us how to cope with that and those emotions. And really, I think as an individual, when it happens, when I had the event, it was a couple of years ago now, it was talking to friends, talking to family, drawing on strength and support, and going through the process, which I was exonerated in. It was a very hard process, and I think it's really the support you have around you is the most important thing.
Yeah, and I think I just need to interject there, because this particular case which Ginny is referring to is one she managed amazingly. And it just goes to show how, you know, if we have a bad outcome, we can, even if we've done brilliantly in their management, we can be left with a real sense of failure, even when everything's gone as well as it can be. You know, if we lose a patient, we can be totally devastated. You know, nothing needs to have gone wrong for us to go home and just feel really bad about things. And really consider, I don't know how many times I've just, you know, written my letter of resignation, deciding I can't do this job anymore because the emotional impact is too big, even when I haven't done anything wrong. And it really goes to show that actually nothing needs to have gone wrong for us to really be beating ourselves up about it. Peter, how do you manage with failures?
Yeah,
what's your strategy?
It's always worth speaking last, isn't it? Because everyone's answered all the questions you were going to. So I've written a few things down, and firstly, I think, you know, there's only a very minority that actually goes to work to actually want to harm a patient. So like a Shipman or, you know, Patterson or what have you. So, you know, 99.9% of us go to work because we want to help patients, but because of the work that we do, you know, it's inevitable when you do a craniotomy, or you do a prostatectomy that I do, or you do open heart surgery or whatever, there is you are cutting into a patient. You know, you are instantly causing harm, in inverted commas, you know, by cutting into a patient. So, you know, whatever we do, there is a risk, and of course all surgery is a balance of risk and benefit, isn't it? You know, let's be honest. So I think I mean, we talk a lot about threat and error management. So you can actually minimize complications, technical complications. I mean, you can have post-op complications, post-op infections and what have you, but in terms of technical complications at the time that you're operating, you can do something called threat and error management, when you're actually thinking ahead about the what if scenarios, and, you know, so you're minimizing risk in effect, and you're improving your situational awareness. I don't have time really to talk about that, but that is a coping mechanism and a strategy that you can do to minimize risk. It's okay to say sorry. People sometimes feel, oh, I can't say sorry because the patient will think I'm to blame for this. Well, yes, you can say sorry, and actually saying sorry is often the first part of healing, if that's the right word, for the patient and for yourself and for the team. And it is okay to blame yourself. You know, it really is. You know, I mean, people, you know, internalize this and think, you know, I've done this operation or whatever. I mean, I remember just a few weeks ago, I did a lovely prostatectomy, went without complication, and then the patient had a paralyzed face afterwards, and I'm thinking, I've gone and cut the facial nerve, knowing that I hadn't in my heart, but I thought I've cut the facial nerve. A few days later, it had completely resolved itself, and, you know, so just a neuropraxia, or very sensitive nerve. But I was beating myself up about that in the evening, thinking, hang on, you know, walking through that operation, thinking, well, hang on, maybe I did cut it, maybe, you know, even though I know I hadn't. So you you know, going through things, externalizing it, talking to others, you know, getting help, you know, a problem shared is a problem halved is a useful expression. And if you work in a team where everyone feels valued, and that's obviously a lot of the human factors work we do, you know, so a trainee can go to the consultant without anxiety, without fear. Greta, you mentioned you went to the surgeon and said, you know, you were scared because you hadn't. I mean, that's not right. That's not right. That needs to change. And the college is actively working on that now with Ginny's passport program, which is going to be brilliant. And there's going to be a human factors course, formal course that we're developing as well. So watch this space. Yeah. I
think I just add to something that Peter said there, that it's a fine line as a surgeon, isn't it? It's that awareness of the problems that the risks that you're taking for the patient effectively, and the problems that you can cause, and not losing the confidence to undertake the procedure. And that it's such a fine line in that, because you can't lose your confidence, but you have to be aware and have the risks, have empathy for those risks. And I think that's part of why surgery is an apprenticeship, because you have to learn that as you develop that skill as you become more senior.
I mean, can I just ask? Can I just ask you both? Do you get imposter syndrome? Sometimes you feel, and that's, you know, no matter how senior you are, you sometimes think, gosh, you know, can I actually do this? You know, that's part of being human and normal as well. It's not a failure.
And I think saying sorry to patients is really good. I mean, I've said, you know, if one of my patients has a really difficult complication, I've sometimes got myself into a funny conversation, because I say to them, look, I am so sorry this has happened. And often I say, I'm not quite sure what I could have done to prevent it, but I'm really sorry this has happened, because this is obviously going to affect you. You're going to spend longer in hospital. That's going to affect, you know, your childcare or whatever else is your ability to return to work. And I've had one patient who says, don't worry, stop worrying. You know, you don't have to apologise. These things happen, and it's really not your fault. And then you kind of think, oh, that's not what I was expecting somehow. But you know, patients appreciate honesty, and they appreciate you acknowledging the impact a complication is going to have on their life. And you know, I've had patients who have had awful complications as a result of, I'm thinking of one particular emergency surgery, who ended up coming back to my clinic after months in hospital. And I said, look, I'm really sorry, you have just had an awful year and you've still got this complication, which means, to be honest, you're going to have another really awful year, and I'm really sorry. This is going to affect your family, it's going to affect your travel plans. I know you were planning to go away for your wedding anniversary and you're not going to be able to do all that, and I'm really sorry it's happened. And patients get it. You know, they appreciate the honesty. They appreciate that you're treating them as humans, not just as, you know, my mum went to a surgeon one day. She said, I just felt treated like a chunk of meat. And actually, we need to treat our patients with respect. And that includes saying sorry when things go wrong.
I think,
Jane, any other questions? Sorry, Ginny, were you going to say? Or Greta, someone was saying.
It was interesting. I was going to say, I'm finding this conversation really, really fascinating, because it's reiterating a lot of thoughts that I've had myself. But I think our experience of failure as medics, we don't really possibly experience even for quite a long time, because at GCSEs, at A levels, we've been, or O levels, depending on our ages. We've been top of the class. You know, we've been top of the class. We've gone to uni. We've effectively, our uni told us that we were in the top 5% of the university academia numerous times in the first year. Majority of time you'll get through university, maybe you fail one exam. It's not a huge blow. Or you might have a project that doesn't quite work out, and then you really only experience your first failure, in inverted commas, when you're at work. And being medics as well, we are taught that success is getting a patient home. We treat, particularly surgeons, we have that fix it mindset, don't we? If something is broken, you know, the orthopods, something's broken, I'm going to fix it. Brilliant. That's what we like doing. We like taking out the badness, making you better. So actually, if somebody dies, then we see that as a failure. if something goes wrong or we cause harm, then we see that as a failure as well. So I think that there's definitely something to be said about sort of the training and the education, and like we sort of saying how you deal with it, and understanding that this is going to be a lifelong part of your career. This isn't ever going to change, and actually probably the more experience you get, the stakes get slightly higher. And I think it's very interesting that we're talking about this from a sort of patient perspective, which is clearly the most important. But I also think that the higher up, inverted commas, that we get, we start to, you know, professor, book writer, head of KSS, we start doing projects, we start doing research, and actually, again, we're not used to those projects failing. We're used to everything that we're doing working. When I was at NHS England during COVID, when I was doing some of my leadership fellowship, I remember the first thing that two of the bosses said to us was, if we're going to do a project and it's going to fail, we want it to fail quickly. And this was a very sort of open discussion about, we know that projects don't always work. We know that the stuff that you're doing doesn't always make it to success. So if it does, we want to get it to fail quickly. And Matthew Cripps, who's a great behavioural change academic, always talk about trying to break things. So you would get your solution together and then you would try and break it, you try and make it fail in a very sort of pre-mortem ethos, so that you could work out the stuff to try and fix it, to try and make it have that success. And again, we don't get taught that side of things at medical school or in our training. And I think it's something that, again, we need to be more open about.
And it still doesn't go away, actually. I mean, you talk about research and things. So I'm very much an NHS surgeon. I've got a personal chair, but so I love writing and collaborating with others and helping trainees and whatever. So I think I've got 600 papers now, but even now I get papers rejected, and it's really actually gets you right there, you know, even though it's like it doesn't really matter too much, but actually it does matter, you know. So it doesn't matter how senior you get, Greta, it still affects you, and it's upsetting, and it's like why, and you try and blame someone else, you know. Oh, why did I fail that MRCS, or it's your fault and it's not fair, and you just have to take it on the chin and try again and resubmit the paper, or make it better, or try the exam again, or what have you, you know, and just accept that even then you're going to have more failures as you go along. Yeah, it's part of life, sadly.
I'm going to move us on because we've only answered one question. We've still only got 20 minutes left.
I'm going to put out there now that I don't think we're going to get to all the questions because they're coming through thick and fast. I'm going to try and sort of
we'll have to maybe not all answer each question. Yes,
we might need to, but actually you have also ticked off some of them as we've gone through, so you effectively have already done a couple, so so we are moving in the right direction. We've had quite a few people messaging in asking about how you balance and cope with the sort of impact of personal experiences or issues, so things that are happening in your private life that might then impact your work life, and how do you come to terms with them and manage them? Is it okay to say, actually, there's too much going on, I need to not operate, I need to take a step back, those sorts of, so there's lots of questions on those sorts of themes, the impact of your personal life on your work life and ways that you can cope with that and help manage your sort of like work mindset. There's a lot there.
There is a lot. Does anyone want to start?
Do you want me to take that then, seeing as I was last on the last question? I'll be really quick. So emotion and stress does affect performance. So if you're angry, you're about 30 times more likely to make a mistake. And you know, and we take emotion to work with us. So if we've had an argument, we're getting divorced, whatever it is, you take that to work with you. And it's learning how to manage it. So the Olympic athletes, I think Victoria Pendleton had a coach. So she had gremlins about about another cyclist beating her. So she had the chimp scenario. So it was a cage. She was taught to put the chimp into the cage on the shoulder, lock the door to the cage and throw away the key. And so she parked those emotions and those things until after the race, and then she let them out again. It's easier said than done, actually, and I can't really explain it in a I'm not going to say any more, but there are coping strategies and things available. Yeah, but it's difficult.
Karis, can I? Yeah, I think that there are coping mechanisms, but sometimes you just have to admit that you're human, and there are times when your personal life can interfere too much that you do have to acknowledge that you need to take a break. And I suppose because I mean, this resonates a bit with me because as I've got 4 children, but 2 of them are autistic with severe learning disabilities, the twins, and there came a stage when I realised I could no longer look after them at home because their disabilities were so severe, and I was a single mother. And going through the process of getting them into residential school where they're 52 weeks residential, really I went through a whole grief process, and I tried to work and I couldn't. And that's had to have some counselling because it was like a grief response as if I'd lost them. And at that stage, I had to acknowledge actually I couldn't give my best to my patients, and I had to have some time out. So I think we are human. We have lives. We are paid to go to work and do a job, not to take our emotions to work. But I wouldn't have been able to give to the best to my patients during that period. When it's making me feel quite emotional just talking about it. So I had to acknowledge that I was a human and not work during that period and seek help. And PHP were able to help me at that time. So yes, there are times when life does get in the way, and you have to admit that that's the case.
And that's another of those times you need supportive colleagues who are going to say, look, this is really, but this is awful what's happening at home. Take a break, we'll cover your clinic, we'll get you a senior trainee to support you, or you really need, or if you're a trainee, you really need a supportive consultant.
But then you try and turn it into a positive. So what we did was I've launched the campaign at Medway for Different Not Less, for an understanding of autism and learning disabilities, which we're hoping to spread further to change that into a positive from a negative. So I went through that emotional time, but then have now turned that into something positive that I'm creating from it.
Yeah.
Yeah, positive energy is really powerful, isn't it? In fact, just before we came on, we were talking about writing a paper about this and a few other things. So thinking about positives, even though failure is a negative subject, look at the positives if you can. Yeah.
Can I just say, by the way, because you've all talked about failing exams, I also failed, because I kind of feel the odd one out. I also failed MRCS and FRCS.
Yeah. Aren't we?
I feel I'm, missing out if I don't. Sorry, Greta, were you going to say something?
No, I was just going to quickly say as well. I suffered very bad migraines in my ST4 year. I got vertigo with them, so it felt like I was drunk, and it looked like I was drunk. And I had 3 months off where I basically couldn't walk. I was just on the sofa. And coming back to work was incredibly hard. Fortunately, I was very well supported by Oki Health and very well supported by the consultants, the trade. I cannot say a bad word against any of that. But it was really that I remember being in clinic one day and thinking, Cor, I'm probably pushing myself too much. But I was only seeing 4 patients, but I remember by the end of it, I'd got this raging migraine. I just remember sitting there thinking, I do not care about what you're telling me. And it was a real sort of wake up moment of after that clinic, I thought, right, I need to go home for the day. I'm not in a good place. And made sure I had the next day off. And again, they were very sort of supportive in that. But I think it's sometimes, like you say, Jenny, being able to have that insight, and also being in an environment and in a culture where it is okay to say, hang on a minute, team, I'm not all right at the minute, or hang on a minute, team, I've got some stuff going on outside of work or inside work, and I really need to have a break, or I need to take a couple of wellness days, or I'm not going to be able to do that operation because X, Y, and Z. And that's why I think these webinars are so important, so that we are showing that we do have this culture, trying to perpetuate that and make sure that that is really driven home, sort of right from the leadership all the way down across to the trainees.
Definitely. Jane, shall we try and get through a few more questions?
That brilliantly segues us into a couple of slightly different questions as well. So lots and lots of positive comments coming through as well. I will share them with the panel afterwards because there's some lovely people saying some lovely things. So I will be sharing those with you afterwards because we haven't got time. So there's sort of two that I'm going to mesh together a little bit, sorry. So one is we've made a lot of comments about trainees and medical students and supporting trainees and culture change and all those sorts of comments. We've had a message in from someone from our SAS grades saying, this is all brilliant, but what about us? How can we support our non-training grades who quite often may find themselves just in a less structured environment to get the support that you guys have been talking about? And then in a similar sort of vein, I'm being quite tenuous, we've also got somebody commenting about the fact that this again is all great if your team is supportive and your wider organisation, but what do you do when your team isn't supportive, and what if those mechanisms aren't there?
Can I answer that as a RCS England Council member? Because you know, you as SAS doctors are hugely valued. You know, you do a fantastic job. You provide a brilliant service. In fact, we talked about this at the RCS Council meeting today, and the college needs to and will be doing more to support you. You know, and I can say that as someone who was at the council meeting today. I think you have so much to offer, and you need to, you know, you cannot be a second-class citizen, and you should never think that. You should be an equal to every other member of the team, and we should be doing everything to support you as we should everyone else in the surgical team.
I think if you read the document that I put up on my slide, that applies to all grades of doctors, and the recommendations were for trusts to create these first responders who would need training. And I think that's something that I mean, I'm taking on from the basis of being head of school, but if every trust was to do that, that would be available for all surgeons, independent of whatever grade they are. So it would be nice to see that this could be taken up, and this role could start to be seen in trusts to support everyone.
Yes, one of my my challenges, newly appointed medical director, is how we do that at the Medway, and that's definitely something I want to introduce for maybe not just for our surgeons, but for other clinicians as well. But I think, as I said at the start, I think we as surgeons are particularly affected because the outcome of patients can be so directly related to our technique and to the way we manage our patients as individuals. I think, yes, I mean, I think it's really hard going on to the point about what do you do if your department's not supportive. That's a really difficult and can be quite an isolating experience. It's helpful if you've got people who understand surgery outside the trust, so colleagues in other trusts. It's helpful if you've got colleagues in other departments, especially other surgical departments, who will support you. I think, you know, it's really nice if we've got friends and family who support us, but it's really much more helpful to have colleagues who are also surgeons who understand what it's like to have a significant complication. I think that the document the college has produced, as Jenny says, is a really good one about having first responders for surgeons, because I think that may well fill the gaps that some of the trusts have in being able to provide people with that support. And we really need to look after people who have been involved in serious incidents, because yes, we definitely need to learn from them, but what we know, having someone involved in an SI who goes off long-term sick or is really mentally damaged by the incident is really poor outcome for everybody. And so we really need to be supporting each other much more. So yeah, I don't think I've got much more to add to that one.
I'll just echo what you've said there. Really, I think as a trainee, I think you know when you're in a bad unit, inverted commas, and you know when you're in a good unit. I think the most important thing is trying to create networks for yourself, so that, let's say, Mr. X or Mrs. X is going to shout at you about something, or is not as supportive as perhaps you would like them to be. Having somebody like Ginny as your head of school, or knowing that you can approach, you know, come find me on Twitter and we can have a chat about it. I think even sometimes it's just having a friendly ear to talk to just be like, oh, I can't believe this has happened. So like Cara says, it's your support network, but I think it's also about finding allies that will actually say, much like we're trying to do with the bullying culture and that sort of harassment culture, is actually finding somebody that you can go along to and it's got some clout and say, this has happened, I don't think it's okay. And knowing that that person on the other end of the phone or on the other Twitter message or the email is going to say, yeah, I agree with you, this isn't good enough, here's what we're going to do, or my hands are tied, I can't do anything at this point, but I'm here if you want to talk. I think finding those allies are, I mean, they are worth their weight in gold. And I'm happy to be a friendly ear to anyone on Twitter. Do find me, or send me an email. I think I'm the only Greta McLachlan on the NHS, so it's nice. But yeah, more than happy to be contacted to discuss. So yeah.
And I think we're all on Twitter and all happy to be contacted. Do I speak for everybody there?
Yeah, not all at once. Please, not all at once. Otherwise, we're all going to.
Sorry, I didn't want to volunteer all of you, but I thought if I led that, then you'd probably do the same. Yeah.
Yeah.
You're saying about allies. I mean, I've got Caris as a colleague, Caris and our friend Shirley, another colorectal surgeon. We have a WhatsApp group and we're just support. I've drawn so much support from Caris and Shirley as fellow surgeons, and I know, you know, there's been times when I give support as well. And I think having that kind of network to fall back on has been so important for me at Medway.
I mean,
Sorry, we're all talking at once. I think the other thing I just wanted to say is that one thing I've started last year, which I found really helpful, is I actually have long-term, regular, twice-monthly counselling sessions. And quite a lot of those counselling sessions, I don't need to talk about any of the stresses in my life and, you know, what my kids are doing or this, that and the other, and they're more of a chat. But actually there are times when it's really helpful, and what's been really helpful about those sessions is about looking at how I think and how I process. Because when something happens, you have a certain amount of reflection, which is good and useful. And then if you're anything like me, you then go into the hours and hours of overthinking stuff, and then lying awake at night, and the 3 a.m. is overthinking. And what I found really useful about these sessions is challenging my thinking and because all that overthinking was just, you know, at times it just left me exhausted. And also it was useful time I needed to be thinking about other things like the kids' birthdays or Christmas presents or, you know, other stuff, you know, sorting the house out. And with all that thinking, it really takes your mind away, and you get stuck on this one thing and you can't move on. So I've said to several colleagues, you know, don't be afraid. I've said to when I started the counselling almost a year ago, I said, look, you know, I want to stay in this job for at least another 6 to 8 years at a minimum, and therefore I'm employing you. I want to have these sessions twice a month, every month for the next 6 to 8 years, because I think I'll become a better surgeon and a better doctor because of it, because you'll be able to help me look at the way I'm responding to things and look at, you know, critically about how I'm managing them, and look at the things which are useful and not useful. And actually having that external perspective by an expert has been hugely useful, and she's been able to say that you're taking responsibility for that again, and it's not your responsibility, and those sorts of things where you think, oh yeah, you're right. So don't be afraid to get help, you know, is what I want to say. Sorry, everybody else wants to talk simultaneously. Who was next? Greta, or was it Peter?
No, I'm happy to go. That's a nice place to end on that. I was happy to go for the next question.
Okay, next one, Jane.
Oh, so many. Okay, so we're again moving quite nicely on. We've had quite a lot of people commenting about the importance of leadership and the importance of leaders demonstrating that it's safe to fail and that it's a safe space. And I feel like we've covered it a little bit, but specifically somebody has asked about your sort of personal experiences of leaders, and if there's anyone particularly or a style of leadership that you think has been really helpful in how you manage your sort of professional, personal, whatever kind of failure you wish to allude to, whether it's failing an exam or whether it's something a little bit more serious in theatre. So yeah, any inspirational leaders or leadership styles that you can recommend?
Anyone want to start with that one?
Got to think on this.
Yes, I need a bit of thinking time.
Do you want us to come back to it?
No, I can answer from my perspective of leadership style. I remember being a registrar and doing some form of colonic procedure, because yes, I was trained as a general surgeon before I did vascular, and I cut a ureter. And I was just like, oh my God, I've cut a ureter. And the consultant, I thought, right, it's going to come now. She's going to shout at me because I cut a ureter. And instead, the consultant at the time said, oh, why has that happened? That ureter's in the wrong place. And why is that? And instead of shouting at me, looked at it, and actually the patient had undiagnosed retroperitoneal fibrosis, which shows you how long ago it is, because they hadn't had a CT as part of their workup, because now everyone gets a CT. And they were stented, and the reason for their retroperitoneal fibrosis was found as to why I'd done it. But the whole learning for me was that I felt even more guilty about it because I wasn't shouted at, rather than if I'd been shouted at and I would have been, well, he just shouted at me anyway. But it was so refreshing actually to have someone not shout, look to solve the problem, look to see why I'd done it. And that was at quite an early stage in my career. I think I was a second year registrar, and that definitely made me realise that actually it's more effective. It's never good to shout, never ever a good idea to shout. There's no reason to do it or lose your temper. But actually, by being much more, why has this happened, was the right approach, as he was my leader, as my consultant or my educational supervisor were at that time. And I think that was definitely a good learning point for me as a trainee. And we use our consultants for our role models. We pick and choose things from our consultants. We pick good things from them, and we pick bad things from them. I've been in a RETA and was asked what I'd learned in the last 6 months, and it was how not to be a consultant, how not to treat my trainees. So there are certainly those sorts of people. And I didn't learn anything from that boss, but I learned an awful lot from this gentleman, who was a gentleman who didn't shout at me. So I think, that's the sort of leadership model that I followed and chose to at that stage.
Yeah, I think it's so important to have those role models when we're training, because you choose what you like. A bit like technique. You say, I like that technique, I don't like that one for doing that anastomosis. And it's the same with the leadership styles. You think, I really like the way they did that, the way they managed that really difficult, that really upset family, or that really difficult situation. I want to do that too. That's what I want to be able to do as a consultant. I can't think off the top of my head of anyone specifically, but there's certainly bits and pieces I've picked up from lots of different bosses that I've really admired, and I thought, I really like the way they do that. I like the way that they take the time. I like the fact they don't shout. I like the fact that they are able to see things from my point of view, or how I might be feeling. I like the way they negotiate that really tricky situation. That's what I want to be able to do too.
We're probably talking about more compassionate or inclusive styles of leadership as being the right model to follow.
No, go for it, Peter.
No, please, after you.
No, it was really just another sort of quick anecdote from that very similar thing, where a very good female boss that I greatly admire, who, when I was doing a chest drain on this elderly gentleman who's got a massive hemothorax, and she came in to sort of supervise me and said, "Oh, have you got a group and save?" And I was like, "Oh, I'm pretty sure we do." And then suddenly thought, "Oh, poop, I haven't checked if we've got a group and save." So she went on the system and checked, and there wasn't a group and save. And she looked at me and she kind of went, "Probably would have been quite helpful to have a group and save, wouldn't it, Greta?" I was like, "Yeah, probably would." As I cut and this huge amount of blood came pouring out. Not really anything else I can do at this moment. And actually, he was fine. He wasn't exsanguinating or anything else. But again, it was just the phrasing and the sort of like, you've messed up, haven't you? And I can guarantee you now, every single patient I do anything on, it's always it's now, have they got the COVID and have they got the group and save? And I touch wood, I haven't forgotten since that moment. But very easily could have been understandably quite miffed and sort of could have shouted, could have, or, you know, not even shouted, just, you know, a tone on her, and actually chose the sort of, probably would have been sensible to have a group and save, wouldn't it? And that stuck with me for, you know, however many years later, and I've definitely not forgotten it. But it definitely is that compassionate leadership that Michael West talks so much about, is compassionate leadership, having that sort of humility side to you, that sort of Brene Brown authenticity, and sort of being able to talk about these things. So yes, I could wax lyrical leadership for a while, so I will stop there.
And just remember that most people that shout, they actually regret it afterwards, and you know, they go away and they reflect on it and they regret. Not everyone, but most people do. And also, if you shout and you get angry, you're so much more likely to make a mistake anyway. So need to step away from that environment.
Yeah, I got really grumpy in theatre the other day, and I said, "Rrr," and then I thought, and I went back to my trainee and I said, look, I'm really, really sorry. I should never have got grumpy about that. That's totally my fault. It wasn't actually anything she'd done. It was just the situation we were in. You know, as you know, sometimes theatres don't run as smoothly as you want them to. And I just said, look, you know, this is the situation. It's out of everybody's control. I should never have got grumpy with anybody, and I just want to apologise. And I think apologising when you know, to your trainees and to your theatre staff who have to suffer your bad temper from time to time is really important too.
So powerful as a trainee if your boss apologises for I mean, it's even, I think, weirdly, I think it's even more powerful than not shouting, because I think, like you say, it shows that humanity of, oh, actually, I'm not like that. I'm really sorry that happened. Yeah, as a trainee, it's incredibly powerful when that happens.
And unless you've got an acute situation where you've got a bleeding aorta, or you've got something that requires immediate, it is perfectly acceptable to actually to step back from the situation just for a couple of minutes to let things diffuse. And you even do that at the team brief, and you say, you know, if we get into position, we will stop or we'll step back, so everyone knows it's going to happen. So that's that threat and error management and things I was talking about earlier. You never want to get into that position, because if you do, you'll regret it.
There's definitely times when you just put the packs in and you just sort of stand there for a few minutes to gather your thoughts. I mean, I think we've all certainly done that. Put a pack in,
call a friend,
phone a friend, and just diffuse the whole situation. Yeah.
It looks like we need to do another one of these, don't we? Really, with all the questions coming in. Yeah.
I was just going to say, Jane, we're just getting into our stride, and our hour is up.
I know. I'm really, really sorry. So I think my colleague Imna has just popped a message in the box. It would be great to carry on the conversation over Twitter if the panel are happy to. I feel like there's still a lot to say, and I do feel like there's probably some scope for us to do a few more focus sessions later in the year. So again, not putting any pressure on anyone, but is that okay?
That would be great. I think this is such an important topic, and the fact that so many people have shown an interest in this, I think, shows how much it resonates with the surgical community, and how important it is that we talk about it, and that we compare experiences of how we do this. So that would be great. I guess, shall we just have any particular last words from the panel, because I think we have to end now. Any last thoughts, final thoughts? Greta, put you on the spot.
I think don't be afraid of failure. I think it's going to happen to all of us at some point, and anyone that tells you that they've not had a failure or a complication is just a liar, or deluded. So I think if anyone ever says, oh, that's never happened to me, well, you can put that down to them being I was going to say a naughty word then, but I won't. Yeah, I think just put them down to them being a bit deluded and move on, and realise that that's their problem and not yours.
Yeah, Ginny, final thought?
I was just having a bit of fun with my internet. Probably my eldest on his PlayStation. I agree with what Greta says. You know, we all have complications and adverse events, and we have to be aware of the impact it has, not only on our patients and their families, but also on us. And by the fact that we have opened up and said this, I think hopefully that will give people some reassurance that they're not the only person that's having those emotions. And the more people that talk about it, more surgeons that talk about it and open up about it, the better that there is. But well-being, particularly after the year that we've been through, can't underestimate how important it is that we look after ourselves, whether that's through physical, going for exercise, or whether that's through, as you said, Keris, having counselling. We need to look out for ourselves, and we also need to look out for our colleagues. Thank you.
Thank you. Peter.
Yep, I just come back to the first thing that I said, or at least I think the first thing I said is that error is normal. You know, it's part of everyday life, and we will have error and we will have mistakes and failure. And the main thing is just to learn from it. You know, so try that it doesn't happen again, and try and look at a positive thing as well. You know, try and rather than focus on the negative, what positive can we obtain from this for us and the team? And I'd just like to thank everyone for joining us as well. It's for giving up your evening. It's thanks so much.
Yeah, definitely. Thank you for everyone who's participated. And I guess I'll leave just with my favourite quote from Winston Churchill is that success is going from failure to failure without loss of enthusiasm. I think that's probably my favourite.
Yeah. Yeah. Brilliant.
Thank you all ever so much for joining us. Thank you to everyone who's joined online and submitted questions. Sorry we couldn't get through them all, but I'm sure we'll all be active on Twitter. Well, we're all active on Twitter anyway, so we'll carry on this conversation. Hopefully we can come back later in the year to carry on. Thank you, Jane.
Thanks very
much.
Much.
Thanks. Good night.
Thank you.